Thank you very much, Professor Blanc, for the kind introduction, and thank you for inviting me in this wonderful Congress. It's a great honor for me to be here. To be honest, it was very difficult to select some papers regarding imaging because imaging is everywhere. So you can use imaging for diagnosis, for the evaluation of prognosis, for risk stratification. So imaging is one of our tools in clinical practice. So I decided to divide my presentation in three main pillars: primary prevention or risk stratification, if you prefer, the evaluation of ischemic heart disease, and finally, the evaluation of valvular heart disease that, according to the last guidelines of the ESC in 2025, it's one of the probably the most challenges issue in cardiology. And I think that we are in a learning curve. What about primary prevention? So this morning, during the opening ceremony, we discussed about the importance of numbers to produce results. And I would like to show you some papers that I selected according to the use of big data, big numbers, big population. Because if you use this kind of data, according to what Professor Rank said before, so you need to be sure that you select the best patient to have a very robust registry. You produce it at the end very strong results. And I think that this is one of the best explanation of how you can use data. This is a very interesting Swedish registry with more than 25 patients. And you see that if you collect data from CT and for cardiac CT and for vascular ultrasound, you can stratify your patient, and you can stratify also the difference between men and women. So accordingly, you can see here that men had a very, very high prevalence in terms of imaging detected carotid stenosis, but also coronary artery disease. So accordingly, you need to keep in mind that there is very big difference, and you can find also in a symptomatic patient this kind of data. The next point is how you can use it, but this is the real situation in a standard population. And again, this is a longitudinal cohort of a very big number of patients, and you see here that these are not asymptomatic. These are symptomatic, very young patients. And you see that sometimes, okay, this is a young patient. These symptoms probably are not robust symptoms. This is not very standard symptoms. But again, if you see this population, you can see that even in presence of very young people, symptomatic patient can be a diseased patient. So again, don't forget that even in presence of young patient, you can have the disease. And so CT and echo can be useful to detect it. And again in a very young population, this is another very nice study that show you the interaction between different kind of big data. So risk stratification in terms of risk factors, evaluation of symptoms, prevalence of, for example, blood pressure alteration, presence of renal insufficiency, and imaging data, such as imaging coming from CT and from echo. In these cases, from calcium score. So again, you can see here that if you combine all these data, you can detect a very, very high risk patient. And again, we discussed this morning about the importance of artificial intelligence. And this is a very, very nice study. And these authors use artificial intelligence to stratify and to create a sort of machine learning data analysis, and to use this data to produce a sort of new score for stratify the patient. And this is very, very interesting, because if you observe this kind of models applied to the standard situation, it seems that it works very well, and it can add something new to our clinical decision making. And finally, again, the deep learning methods using CT data. So we can use this data to evaluate something different, something that we generally see in CT, but we don't use. But with AI, we can measure also the impact of the body composition. And I think that it's very important because, so in our last discussion with Mark Dweck, he said that, ischemia is the consequence and plaque is the cause of myocardial infarction. But if you see this data, probably it's not true because plaque is again a consequence of something different. Plaque is the consequence of metabolic alteration. Plaque is the consequence of inflammation. And I think that if we can merge all this data, we can learn something new. We can use other parameters like, for example, metabolic alteration, presence of fat, abdominal fat, fat in other settings. We can use all this data to stratify in a different way our patient. And accordingly, this is another very nice study that used, for example, skeletal muscle adiposity for evaluating presence of microvascular dysfunction. And you see here that if you combine all this data, microvascular dysfunction and presence of fat in the abdomen, you can increase the evaluation of your patient and the stratification of your patient. So use all this information to analyze in a different way your imaging data, not just to see presence or absence of coronary stenosis, but also presence or absence of something different that you can use for further evaluation. And finally, I show you some data about CT, about echo, but also CMR. And this is probably one of the best setting that you can use CMR because the UK Biobank have the possibility to combine a lot of data in a standard population, like in population with disease, and you can use it to evaluate different kind of things. And this is a very nice way. So you see that there is a big amount of patients, more than 40,000 of patients that were analyzed in a retrospective manner, but in a prospective cohort of patients, of course, to evaluate if there is a sort of link between biomarkers and CMR in the evaluation of thickness and motion, to evaluate if there is something that can be added in the finally detection of risk stratification. And again, they use artificial intelligence tools to evaluate that. And at the end, it seems that it can predict not only the presence of ejection fraction abnormalities, but also the presence of arrhythmias. So this is another way that you can use artificial intelligence and big data to show something different. But you can have these results just if you have these kind of numbers. And this is another way, because I love it, because this is one of the first papers that we published in our journal, and you see that the amount of patients, of individuals that were enrolled is incredible. But in the end, the authors are able to evaluate a sort of distribution among normal hypertension, bicuspid, and Marfan population. And you can see that it can be done just in presence of such type of numbers. But again, this is another paper published with the same number of patients, and at the end, the authors say that even if you are in presence of dilation of aorta, it doesn't mean that you can have dissection. This is a sort of paradox. Again, as I said at the beginning of my talk, you can see something, but you cannot say that in presence of what you are seeing, you have necessarily an effect. But you need to evaluate what you are seeing with other parameters, and then you can try to define what can happen. You can observe, you can use your clinical decision making, but not just in front of the imaging, but you need to combine everything to stratify your patient. And even if it's true for risk stratification, it's mainly true for ischemic heart disease. I think that here we are in presence of probably one of the most important trials that were published for coronary artery disease, and I am referring to the SCOTART that changed it in some way, our way to think and our way to treat our patient. I think that the SCOTART trials, and please, Pascal, correct me if I'm wrong, is one of the most elegant trials because it's a randomized trial, but they randomized patients that were treated in clinical practice according to the protocol that they use in UK, and they randomized just to CT. So they use CT as something different, as something new, and they evaluate the role of CT after in terms of how they treat the patient. So it seems that CT changed the outcome of the patient, but it's not the CT that changed the outcome of the patient. It's that in front of the CT results, you can stratify better your patient and you can treat in a different way your patient. And again, the authors in this case, to increase the number of patient population, combine PROMISE and the SCOTART trial, and at the end, they say that the use of CT, the use of what are you seeing can help the outcome, the follow-up of the patient, because you can change the treatment. You can add statins, you can add aspirin, you can add, for example, revascularization in presence of very stenosis, very critical stenosis. So CT can be of help. It's not CT that can increase the outcome, but it's the way that you can use CT plus other imaging, other variables that you can have from clinical analysis and evaluation. And so I think that it's really very important, but it's not only for CT, but the authors in this 10,000 patients show the same with nuclear. So again, the use of ischemia, the amount of ischemia can change the way of treatment. And so you see here that in this case, if you can treat better your patient, you can increase the survival of the patient. But not only in terms of ischemia, but also viability. The use of viability, the appropriate use of viability can change the way of treatment. And also in this case, you can increase the outcome of your patient. But I think that this is one of the best trial that was published in European Heart Journal according to the use of PET, but not for PET, because the authors say that you need to speak with your patient and you need to force your patient to be adherent to the correct lifestyle. This is very important because if you can use a correct lifestyle in terms of diet, in terms of adherence to the therapy, in terms of use of gym, for example, so it increases the outcome of the patient. And I think that it's a really very nice study, very simple, even if very difficult to plan for PET and so on. But at the end, the results are very encouraging. So use diet, use optimal lifestyle, and you increase the outcome of your patient. And again, as I said before, PET and CT for the evaluation of calcium score, of plaque burden, all these data coming from AI in terms of the adding something new to collect more data to stratify your patient. And I would like to show you in my last 5 minutes something about valvular heart disease. I think that valvular heart disease is one of the most challenging issues in cardiological practice because it's something that we are building in time, so we have no really long outcome of our patient. Valves are completely different from if we analyze the new valve to the valve that we used 5 or 6 years ago. So I think that we need to learn, we need to change the way of observe and to evaluate our patient. And also according to the guidelines, the new guidelines that reduce the age of the patient to implant, for example, TAVI, we need to be very careful in evaluating our patient and to treat and to evaluate the patient in the outcome. So accordingly, this is a very nice study. And this is a study that showed the difference in cardiac response after transcatheter aortic valve implantation. And they use echo to evaluate the flow and gradient pattern, and they conclude that after just 1 year, I think that 1 year is not enough, but it's just to start. And they say that the best outcome were achieved in presence of smaller diameters of the left ventricle, and you can have also the greater increase in ejection fraction. So echo is necessary to evaluate your patient, but again, you cannot use the standard echo. You need to measure everything. You need to use echo as is best to measure, and why not also 3D echo if you have it, to measure everything, to have the collection of the whole data, and indexing also for the body mass index of the patient in order to be sure that your data are the best data to evaluate your patient. And again, this is another very nice study where you see how the TAVI patient, the outcome of your TAVI patient in presence of low flow and low gradient aortic stenosis. And again, if you are in front of this kind of patient, you cannot treat this patient like the other TAVI patient. You need to be sure that these patients are a very selected population, and you need to observe better this kind of patient because they represent a very delicate, very special population, and you need to treat them with a special interest. But it's not only TAVI, it's also functional mitral regurgitation, and you need to check for atrial and ventricular functional mitral regurgitation because it's important to understand that this kind of mitral regurgitation are not the same, and so you need to check very careful with echo. Echo is the best at the beginning in front of which kind of mitral regurgitation you are, and just to be sure that you treat and you observe in the best way. And finally, again, so you need to observe the regurgitant volume to the left atrium in patients with secondary mitral regurgitation. That is different from the first one. And this is the trial, this is the co-op trial, and the results are very interesting, just also in terms of hospitalization. So again, use echo to evaluate your patient, and use anamnestic data to evaluate your patient. Merge all this data to put the patient in the right place to observe them, to use the best valve and to use the best treatment. But you see that we are in front also of the new challenge, tricuspid regurgitation and outcome. For example, again, in mitral valve transcatheter edge-to-edge repair. And you can see here that they also observe this change in stature of tricuspid regurgitation because when you treat a valve, the valve is not alone. You are in presence of a very complex system. So if you treat a valve, you can have a side effect on the other valve. So you need to be sure when you treat a valve, you can observe also the results in the other valves. You need to avoid to have a different disease. So you need to treat a patient and you need to treat for that problem. You did not create a new problem in the same patient. So this is a very strong message. And finally, this is another very nice study, mitral regurgitation evolution after transcatheter tricuspid valve intervention. So again, do not create a new disease when you treat a patient. This is a very, very important point. But for doing that, you need to check very careful at the beginning your patient. You need to check with imaging techniques, but not only, of course, clinical evaluation, symptoms, everything can represent a new variables and you need to dedicate attention to everything in order to treat the patient and to improve the outcome and not to have another disease. Thank you very much.